if left side is affected, okay, his left side is affected. So generally the commonest problem which we can see in case of stroke people here is because there is no muscle power, okay, so the shoulder, the scapula will go for retraction, the scapula will go for retraction, and also humerus will also go for inferior subluxation, or it will also go for retraction. Okay, so because of loss of muscle power, shoulder is more prone for having an shoulder subluxation. Shoulder, the commonest thing. So whenever if you see the stroke people, you can see some humerus dropping little down from the acromion process. Okay, that sign we will call it as sulcus sign. What is that? A gap. Generally you won't have any gap, very small gap. If the gap is too much from between the acromion process and humeral head, we will call this sign as sulcus sign. What is that? Sulcus sign. This shows that shoulder subluxation has happened. To prevent this shoulder subluxation, okay, to prevent the shoulder subluxation, okay, you want to control the scapular retraction. You want to control the scapular retraction. So what is the position which you have to keep this shoulder? In protraction. What is that? Protraction. So how will you give this protraction? Don't have towels and all, small towels and all. Yeah, any small towels? That's okay. So to prevent the scapular retraction and all, okay, lift the patient's shoulder, keep small towel or a small pillow under the scapula. So what is this position now? You are maintaining it in a protraction. Okay, the rest of the things I am taking your pillow because I don't have any other pillow. We will come to neck and all. Okay. So next one is next. Yeah. It should not be too much high. Okay. By next practical we will get the towels everything. Okay. So the first and important key point is shoulder in protraction. Shoulder in protraction. Next one is the whole upper limb should be 20 to 30 degrees abduction. How much? 20 to 30 degrees abduction. Okay. And what about the forearm? Forearm should be in an supination with wrist and fingers in an extension. With the wrist and fingers in an extension. And most important thing here is thumb. What about the thumb? Thumb, generally in stroke people and all, thumb will go like this. You can see anywhere. No? Generally their thumb will go adduction. So you want to keep it in an abduction. Okay. So this is the position for upper limb. So what is the key point? Shoulder. Okay. Protraction. Okay, abduction of the shoulder to 20 to 30 degrees of shoulder abduction, and you have to give support. Next, elbow in an extension, elbow extension, forearm supination, and wrist and fingers in an extension, thumb in an slight abduction. Slight abduction. You can give support pillow, but it should not be higher than your shoulder level. Very thin pillow you can suggest. Otherwise, if there is no pillow, leave it like this, no problem. Only important key point here is shoulder. Okay, for any patient wherever it is, in hospital wherever it is. Okay, so this is in regards to upper limb. Now, the first and important thing here is, next one important is neck. Neck should be aligned neutral. Okay, neutral. It should not be too flexed, too extended. It should not be flexed to either way. It should be in a neutral. It should not be too flexed as. Okay, so you must give a pillow according to that. Okay, next lower limb. What about lower limb? where you will give support, same as what we have given here. We will give here you want to give and no, don't worry, I am not touching. Okay, I have already understood in your previous semester. Someone called me there. Why I am not understanding? Sir, you should not touch over there. Okay, I understand. Okay. So from hereafter I am not touching. But sincerely speaking, without touching the gluteal, you can't treat a stroke patient. Definitely 100%. I don't know how you people will maintain that. But definitely without feeling the, because someone can stand, you stand. Can you stand without gluteal?
No.
Without gluteus, you can stand?
No.
Now, if you want to give how much strength the gluteus is, how can you know that without touching it? I don't know how you people will understand. That's okay. So now here, the important thing here is again pelvis in protraction. Pelvis in a protraction. Then what about the knee? Knee in an extension, and ankle should be in an neutral, not too much dorsiflexion or plantar. Generally, it will go for plantar flexion because of paralysis. So you have to maintain in an neutral, not dorsiflexion, also neutral. Okay. So this is the position in supine lying. What is this position? Supine in lying in supine. Okay. So these are the supports which you. So when you come from head, so head should be aligned neutrally. Head should be, neck should be aligned. Head in neutral, neck in neutral, should not be flexed. Next is the upper limb, shoulder protraction. Okay, abduction to 20 to 30 degrees, elbow extension. I will tell you why you have to keep all these things. Next is supination of forearm. Now extension of wrist, fingers, and abduction of thumb. When you come to the lower limb, pelvis protraction. Okay. Slight flexion of, not extension, it's a slight flexion of knee. Slight flexion of knee and neutral in, foot should be in neutral. Okay, so this is the position in supine lying. Now, if you want to position him onto the same side, if you want to position the patient onto the same side, okay. Same side means on the affected side. So similarly, you have to roll the patient. Okay, but here you must take care for this shoulder. What will happen if you turn without anything? The shoulder may move back. So you must position this. Okay, but anyway, here rolling towards the affected side is easier. Rolling towards the affected side is easier. Why? Because this is active. So he can roll to the affected side easier. If he is unconscious, if he can't, then you can, okay, help patient and to get, okay, then again, okay, neck, head should be aligned in a neutral. The important thing here is again, see that this is in protraction. This should be in a protraction. Okay. The affected side should be in a protraction. No need to give any support for this. Why? Because it is already on the bed. It is already on the bed, no need to give any support. Okay. The upward leg, you can give some pillow and you can maintain the knee in a flexion. Okay. So this is on to the affected side. Okay. Now let it be. Now this is the affected side and you are making it into an unaffected side. Now this is normal, let it be, and this is unaffected side. So how can you give a support? How will you give a support? You have to give a support with a pillow. Okay. You have to maintain it in a protraction. Not like this. In a protraction, give an adequate pillow and give a pillow for this leg. This is onto the unaffected side. Unaffected side. Previously what we have seen is lying onto the affected side.
How many times?
Huh? Every 2 hours. Every 2 hours you have to change the position. No? 2 hours he will be in supine. 2 hours on the affected side. 2 hours on the unaffected side. So this is how to position the head. Okay, stroke patient. Always neck should be neutral. You know STNR? Might be today's class you might have heard about STNR, ATNR in pediatric. No? Now what is here? The problem here is reflexes. That's okay with position? Yeah. Why we are giving all this thing? Why you have to keep it in neutral? Okay? The reason here is, one important thing here is, there is a chance of having an abnormal reflexes. There is if you are not positioning him properly, the first important thing here is, patient will get an abnormal reflexes. That is the first one. Next, if you are not positioned properly, there might be chance of having an subluxation, or in later stages, contractures, tightness may happen. If you are not positioned the ankle in an dorsiflexion or in neutral, what will happen? It will go for plantar flexion, tightness. Later it may cause a deformity, contractions. So that is how positioning is very important in acute stages. So what is the reflexes means? Now, in generally, if brain is affected, the brain will again go for an immature brain, like children. You know? Now you are keeping some bricks and you are making a wall. Once again, if you break the wall, what will happen? The bricks will go away. Similarly, the motor function is because of reflexes. Because of reflexes, you are getting this function. Once, if brain is affected, or if this reflexes come again, like in children, what we have seen in children, then again you will have all these reflexes. Like, if you make the person to bend like this, okay, if you keep the head like this, all upper limbs will go for flexion and lower limbs will go for extension. Understood? If you keep the neck in and flexion, upper limbs will go for flexion, lower limbs will go for extension. This is what? STNR. What is this? STNR. Symmetrical tonic neck reflex. If neck is position flexion, upper limbs will go for flexion. If neck is going for extension, this will go for extension. To avoid this, keep the neck in a neutral. Otherwise, what will happen? The tone in the muscles will get increased. It will go like this. Okay, to avoid this, keep the head in and neck in a neutral. Okay, there is one more reflex called ATNR. ATNR. If I turn my hand like this side will go for, skull side will go for flexion, this side will go for extension. This is ATNR. What is that? Asymmetrical tonic neck reflex. Just keep it in your mind. I am just telling why you must keep the neck in neutral, not like this or like this. If you keep like this or this, STNR will come. If you keep one side or this side, ATNR will come. Means the tone of the muscle will get increased. Later it won't go. Okay. So to avoid all this thing, better keep the whatever the position suggested. Now you have to follow that. It all depends again upon the patient, but these are the key points. But here the key points is shoulder protraction, pelvis protraction, and head and neck in a neutral. It all depends upon the patient and which hospital setting you are dealing with the patient. Okay, so this is the positioning strategies in acute stage of stroke patients. Okay, so after coming from break, we will see the next.